Good evening, everyone. Today we will see about the clinical examination of an ulcer. What is an ulcer? Ulcer is a break in continuity of the covering epithelium, skin, or mucous membrane. It may follow the molecular death of the surface epithelium or its traumatic removal. In this diagram, I have shown the arterial ulcer, venous ulcer, diabetic foot ulcer, ulcer due to skin irritation and rubbing, and the pressure ulcers. History taking. Mode of onset. How the ulcer develop. Whether it develop following trauma or spontaneously. Traumatic ulcers heal by themselves if the traumatic agent is removed. Ulcers may become chronic if traumatic agent persists. For example, dental ulcers on the tongue. Healing of ulcer is delayed if present on the joint because of the movements. Spontaneous ulcers may follow swelling. For example, matted tuberculous lymph node. They undergo coalition and the ulcer develop. And when there is a rapidly growing tumor, we get spontaneous ulcers. Depending on the duration, ulcer can be acute, that is of the short duration, and the chronic, that is of the longer period. Pain may or may not be present. Associated disease, if present, should be noted. Local inspection. The site may give us the clue to the diagnosis. The varicose ulcers are seen on the medial malleolus. Tuberculous ulcers are seen in the neck and axilla. The tropic ulcers are seen on the heel or on the ball of the great toe. These are the weight-bearing area of the foot. Size and shape. Tuberculous ulcers are generally oval in shape. Varicose ulcers are vertically oval. Carcinomatous ulcers are irregular in size and shape. Record the exact size and shape in 2 dimensions. Bigger the ulcer, longer time it will take to heal. Here I have shown the tuberculous ulcer on the neck, varicose ulcer which is vertically over on the medial malleolus, then the carcinomatous ulcer which is irregular. Palpation. Note for the tenderness. Inflamed ulcers are tender. Chronic ulcers such as tuberculous are slightly tender. Varicose ulcers may or may not be tender. Neoplastic ulcers are non-tender unless they have invaginated the local nerves. The temperature. Increased temperature is indicative of infection. Age and margin. The margin is the junction between the normal epithelium and the ulcer, so it is the boundary of the ulcer. Margin is a inspectory finding. Age is an area between margin and floor of the ulcer. It is a palpatory finding. Careful palpation of the edge and the surrounding tissue gives us the diagnosis. Marked induration is suggestive of carcinoma. Certain degree of induration is always present in the chronic ulcers because of fibrosis. These are the various parts of the ulcer. The floor is the exposed surface of the ulcer. Edge is the mode of the union between the margin and the floor, and the margin is the border of the transition zone between the skin and the surrounding ulcer. Skin surrounding the ulcer. The various type of edges such as sloping edge is seen in healing ulcer. There is red granulation tissue in the center, blue zone due to growing epithelium, and white zone at the periphery due to the fibrosis. Spreading ulcers are inflamed and edematous. Undermined edge is seen in the tuberculous ulcer. Punch out edge is seen in the arterial and trophic ulcer. Raised and everted edge is seen in malignant ulcer. Raised but not everted is seen in rodent ulcer. So sloping ulcer gives the healing edge. Undermined edge indicate the disease process causing the ulcer is active on the subcutaneous tissue. It is causing more destruction of the subcutaneous tissue than the skin. Therefore, edges become undermined. In punch out edges, the rate of destruction of the skin and the underlying structure is the same. Therefore, we get the longitudinally going edges of the ulcer. Everted edge which is seen in the malignancy. Here the rate of cell growth is such that the edge of the skin become everted. The floor. Floor is the exposed surface of ulcer. Red granulation tissue on the floor indicate the healthy and healing ulcer. Pale and smooth granulation tissue indicates slowly healing ulcer. Washed leather surf on the floor indicate gummatous ulcer. Black mass on the floor suggests the malignant melanoma. Here I have shown the ulcer with malignant melanoma. You can make out the black mass in the floor. Base. Base is the tissue over which the ulcer rests, better felt than seen. It is a palpatory finding. Floor is the exposed surface of the ulcer, that is inspectory finding. An attempt should be made to pick up the ulcer between gloved index finger and the thumb to feel the base whenever feasible. Depth and involvement of underlying structure should be noted. Trophic ulcer may reach up to the underlying bone. Ulcers bleeding on touch, that is friable, may indicate the malignant ulcers. Discharge. Type, amount and odor of the discharge should be noted. Healing ulcers will show scanty serous discharge. Spreading and inflamed ulcers will always show purulent discharge. Serosanguinous discharge is seen in tuberculous ulcers and the malignant ulcer. Ulcers infected with Bacillus pyocyanin, discharge will be greenish. Surrounding skin should be noted. Grossly red and edematous skin indicate inflamed ulcer. Pigmentation and eczematous skin is seen in the venous ulcers. Scar and wrinkling suggest the tuberculous ulcers. Fixity to the underlying structure should be noted. Malignant ulcers will be fixed to underlying structure due to infiltration. Regional lymph node. Acutely inflamed ulcer, regional lymph nodes are enlarged and tender. In tuberculous ulcer, lymph nodes are enlarged, matted and slightly tender. In malignant ulcer, regional lymph nodes are stony hard and may be fixed to the surrounding structure. In rodent ulcers, lymph nodes are not affected because obliteration of lymphatic tracts. Special tests such as probe to bone test suggest the osteomyelitis. Culture and sensitivity for the infective ulcers to know the causative agent. Doppler study for the arterial and venous insufficiency and biopsy for suspected malignancy and non-healing ulcers. Ulcers are classified because depending upon its etiology as arterial, venous, neuropathic, infective, traumatic and malignant. Then we will know about the sinus. Sinus is a blind tract leading from the surface down to the tissue. There may be cavity in the tissue which it is connected to the surface through the sinus. Sinus is lined by granulation tissue. When it is for more duration, it will be epithelialized. Then what are the causes of persistence of the sinus? Presence of foreign body, necrotic tissue like sequestrum, suture material in the depth, then the absence of rest, non-dependent drainage or inadequate drainage of the abscess, chronic infection like tuberculosis or actinomycosis, when tract become epithelialized and when there is a dense fibrosis around the wall of the tract preventing its collapse, the sinus become persistent. When sinus is due to the osteomyelitis, there will be history of fever, swelling, pain in the bone concerned. Abscess will develop which gradually move towards the surface and will burst and result in a sinus. Sometimes there will be history of discharge of the bony spicule or sequestrum. In case of tuberculosis, there will be history of lymph node enlargement or tuberculous involvement of the bone and joint. Abscess will develop and that will burst as a sinus. Often wide margin is thin and blue and edge is undermined. The discharge. There will be pulse discharge in osteomyelitis. There will be serosanguinous discharge in tuberculosis. Sulfur granule discharge are seen in actinomycosis sinus. Here I have shown you the distal femur, middle part and distal part, which is showing the sequestrum in the center, involucrum in the periphery and the aperture like cloaca below. This is a bone picture of chronic osteomyelitis. This will result in a sinus formation. Surrounding skin shows the scar in chronic osteomyelitis, tuberculosis. There may be dermatitis and pigmentation, palpation. Note for the tenderness. For example, inflammatory source like osteomyelitis, there will be a tenderness. Wall of sinus, if thickened, may be due to fibrosis of the surrounding tissue or it may be due to the chronicity. Mobility. Note whether sinus is mobile. Sinuses result from osteomyelitis are fixed to the bone. Presence of lump in the surrounding structure indicate tuberculous lymphadenitis. Examination with the probe. This will tell about the direction and the depth of the sinus presence of the foreign body or sequestrum, which will be movable with the probe. Whenever whether the fresh discharge comes out with the probe, that should be noted. Thank you all. I hope this all concludes the information regarding the sinus and the ulcer.